Ladies and gentlemen, welcome back to my blog. This is Saturn. I'm a doctor of physical therapy. I'm a board certified wound specialist with the American Board of Wound Management, and I'm also certified in the area of lymphedema by the Lymphology Association of North America, and I am also a fellow of the American College of Clinical Wound Specialists. Today I'm coming back because I want to walk you through the journey of a pro bono patient that I saw lately. But before we begin, let me assure you that any patient that I will mention in this blog is not actually related to any of the patients that I see at work. This is to preserve their privacy and confidentiality. Let's begin. Watch this. This is a case of a friend of mine from out of town who has been seeing his primary provider due to I would say non-healing. It's hard to heal wound who has been present for the last 4 months, and they had tried everything. They have been treating this with a topical antibiotic and putting seroform, and what else have they been trying to do? That's it, and cleansing it with the normal saline. So he was worried, and he knows that I'm a wound care specialist, so he drove from out of town. He came to me, and then I did my assessment. I did my personal recommendation because he's really a close friend of mine. He's actually a distant family member. So I initially debrided this wound in the state of California. We have a direct access, so I did that pro bono. I initially debrided the wound and thoroughly, because I know it's so inconvenient for him to come back every week to see me. So, and then I recommended collagen dressing, what else, and on top of that is Orgo Clean AG with a calcium alginate, superimposed with calcium alginate. And also I recommended electrical stimulation. Lucky enough, I have a portable HBPC electrical stimulation unit, so I gave it to him, and just been doing it every day. The dressing chains wasn't every day, though it's 3 times a week, but just been putting the electrodes above and below the dressing. So after 4 weeks, the wound has healed. Is this a miracle? It's not a miracle. It's science. If you want to know more, follow me. So if you're gonna analyze the case, so what went wrong for those last 4 months of treatment without any progress? So the first thing that I've noticed that is really missing is the diagnosis. So the patient does not have any diagnosis for venous insufficiency. However, presentation-wise, location, it's just a medial aspect. It's a lower part of the leg on the medial aspect, on the inner aspect. That is the territory of the greater saphenous vein. And then also, what else? There is massive edema. There's swelling, and there's also this hemosidrin staining. That is the purple or black discoloration of the skin. That's indicative of the red blood cells being smashed, because they cannot go up, and they're gonna break, and they're gonna release the hemoglobin that has the iron. So that's what we call the iron rust. So she has that all over his legs. And also his occupation is he's actually a retired Did he retire? Not really. He's still working as an on-call RN. So he works in the hospital as a bedside nurse. So those will constitute the suspicion that the etiology of the wound is likely a venous ulcer. So then, of course, you cannot treat something wherein you don't have a good treatment diagnosis. This establishment of the diagnosis is key in the treatment. So we have to know the cause, the etiology. Is it trauma? Is it burn? Is it diabetes? It is neuropathy? Is it vascular? When you think it's vascular, you need to distinguish between arterial and venous. Or sometimes 80% of the time, 20 to 30% of the time, people with venous ulceration also has a concomitant arterial insufficiency. So it's very important that a thorough assessment on the causative factors or the etiology of the wound and the barriers for healing are very important in the treatment of any hard to heal wound. Something is very obvious here. Debridement is missing. Debridement is key in healing in any kind of chronic wounds. Anytime a devitalized tissue reforms at the base of the wound or at the wound margins, they needed to be removed. So the black tissue that you see are necrotic or dead tissue that needs to be removed in order for the healing process to start. So that's the first thing that I did, is I initiated debridement so that all the devitalized tissue will be gone. After establishing that this is a venous ulcer, right? So what is the mainstay in the treatment of a venous ulcer? Okay, it's the letter C. Letter C. Compression. If you have a wound, okay, on the medial aspect of your leg or the inner aspect of your leg, and you have swelling and you have the discoloration of the skin, and you have massive edema, and your clinician is not doing some sort of compression therapy, you need to question the treatment. Okay, so because the mainstay of treating a venous ulcer, stasis ulcer, is helping the fluid to go up in order to help decongest the limb. So compression therapy is very important. An adjunct to that also, well, actually it's no longer an adjunct, it's actually an essential part of treating a wound. If you want the wound to heal faster, yes, you can use physical modalities like electrical stimulation. So electrical stimulation has been used, has been there for in decades, decades. It has been used in the field of wound healing. However, it's not gaining a lot of popularity because number one, it's not an income generating intervention, and number two, it's time consuming. However, if you really want to explore or to optimize the healing potential of a hard to heal wounds, you need to use physical agents like electricity, sound, what else, light and stuff. That is the reason why a wound management is within the area of the profession physical therapy, because physical therapists use physical agents on top of manual therapy. We do a lot of manual therapies in order to improve circulation. Guys, it's all about circulation. It's about blood flow. Okay, so now let me talk more about compression and electrical stimulation. Don't go away. Stay with me. So why compression and electricity help venous leg ulcer heal? Today, we're going to talk about why compression therapy and the use of electrical stimulation are not just add-ons, but actually have a real science behind them in the treatment of venous leg ulcer. If you wrap a leg or hook a wound up to electrical stimulation unit and thought, okay, but what exactly are we fixing here? If you want to know, stay until the end because I'm going to explain to you step by step. So what's really going wrong in a venous leg ulcer? So we need to ask that first so that we can set the stage. In a venous leg ulcer, the core problem is the chronic hypertension. There's too much pressure in the veins of the lower leg. Why? The venous valves are incompetent or damaged. The calf muscle pump, okay, it's actually the second heart in the leg, is weak, stiff, or underused. The blood tends to pool in the lower leg instead of returning efficiently to the heart. So this chronic pooling leads to what? High venous pressure that will raise the capillary pressure. So because of that, there is a constant leakage of fluid out into the tissue. We call that edema. Okay, so now the red blood cells and proteins leaking into the interstitium results into inflammation, fibrin cough, tissue hypoxia, or that's the decrease in oxygen tension on the tissue level. So microcirculation becomes a mess, okay, in such a way that cells don't get enough oxygen and nutrients, and the metabolic waste doesn't clear well. So put simply, the tissue around the ankle is constantly swollen, inflamed, and suffocating. That's the environment in which a venous leg ulcer forms and struggles to heal. So after knowing what is going on with venous leg ulcer, now let's talk about compression therapy. Compression therapy is essentially the gold standard for venous leg ulcers. What does compression actually do? It lowers venous pressure and improves venous return. So the external pressure from the bandages or stockings narrows the vein diameter. It brings valve leaflet closer together and improves the valve competence. And it also increases the flow velocity, so blood is pushed upward instead of pulling to the ankle. Think of it like squeezing a soft tube. The squeeze supports the wall and helps push the blood in the right direction. So it supports the calf muscle pump. When the patient walks or flexes the ankle inside compression, the calf muscles contract against the bandage. This creates a pumping effect, propelling blood back towards the heart. Each step becomes a tiny venous workout instead of a venous disaster. So compression plus walking is a dynamic pump system, not just a static wrap. So when people ask me, is it okay for me to walk? So I said yes and no. If you are just walking without wearing any kind of compression, imagine by just you standing alone, gravity would pull the blood down and you have an incompetent valve. It's gonna, the blood cannot go up. So and then you are exercising, you're walking, and your muscle is contracting and relaxing, contracting and relaxing. During the relaxation phase of muscle contraction, that is when the blood tends to pool on the ankle area more. So if you ask me if it's okay to walk, my answer is yes and no. No if you are not. Let me tell you that the best combo that you can do is put your compression on and go for a walk, because like what I already stated, compression and walking make up a system, make up a very good pumping device or pumping system. So compression plus walking is a dynamic pump system. It's not just a static wrap. So the wrap is more effective if you go for a walk. So now it becomes more obvious that compression reduces edema and normalizes your microcirculation. This is by lowering the venous and capillary pressure, so there's less fluid leak out, so there's edema, there's a decrease in edema, and also it drops the interstitial pressure. So when the interstitial pressure drops, because you're actually evacuating the blood or the fluid, well, particularly the fluid, out of those spaces, the pressure or the congestion in those spaces drops. So when that happens, it improves oxygen diffusion, and also the local inflammation decreases as well. So studies show compression speeds up ulcer healing, reduces pain, and improves quality of life compared with no compression. So the overall effect, compression treats the cause, venous hypertension, rather than just dressing the wound. So a dressing without compression is substandard. You need compression therapy when you're dealing with a venous leg ulcer or any kind of wound, okay, in which edema is present, because always remember, edema or swelling is always pro-inflammatory. It delays healing. Thank you for engaging with me today. Before I let you go, I just wanted to make sure that you won't miss part 2 of this series. This is where I will be talking about this current evidence about compression therapy and electricity in the world of wound healing. These are 2 most powerful tools we have today that would help heal stubborn wounds. And if you are a patient watching this, listen closely. Compression and electricity may be the only tools left that will move your wound towards wound healing when everything else failed. And if you're a clinician, you owe it to your patient to know this science. This is the evidence that changes outcome. This is the evidence that would save limbs. Click on part 2 and let's go deeper to what truly works. See you there.